2019 of serum bilirubin levels. That already should warn you that perhaps the secretory function of the liver is starting to fail. Also, looking back in the past year, for example, unscheduled interventions and/or admissions should warn you of imminent decompensation. This may be GI bleeds or severe infections or else. I am aware the word GI bleeds has been around, and this also necessitates to discuss primary prophylaxis for varices. I will keep it short because, based on Cochrane reviews, we do not have any recommendation for primary prophylaxis in children based on solid pediatric data. This equals the Baveno 6 consensus. We don't have data to indicate efficacy and safety of pharmacological or endoscopic therapies as a primary prophylaxis, and neither do we have pediatric data to indicate that prevention of a sentinel variceal bleed will ultimately improve survival. My personal advice includes to screen for rare but severe complications of compensated cirrhosis. Screening for rare complications are obviously difficult because they are rare. So if you don't screen, you will not encounter major difficulties in general. However, if you miss one of these severe complications, it has severe consequences. And I will call you three here. Hepatocellular carcinoma requires a regular imaging as well as control of tumor markers. We do it every 6 months, for example. Also, to screen for hepatorenal syndrome. This is not as much a chronic condition primarily, but mostly develops upon complications, just as a GI bleed or septicemia. Finally, and frequently overlooked with a long delay at the doctor's side, is the development of hepatopulmonary syndrome. This can be discriminated by a decreased exercise tolerance, but easily to detect by saturation measurements, standing and supine, in your outpatient clinic. Actually, all these three conditions require a rapid step up to the next level of treatment. My final advice involves the assessment of the patient reaching of developmental milestones and his or her ability to engage with peers. Monitor the delay of reaching developmental milestones, including puberty. We all realize that a poor nutritional condition can add to this, but including puberty in your assessment may help you to assess whether this is treatable or not, or you should advance to the next stage. Also, monitor the decline in the ability to engage with peers, both in school attendance, physical energy level, engagement in sports, or lagging behind in growth and psychosexual development with peers. This may actually induce not only biochemical but also developmental delays that cannot easily be conquered, even not after transplant. I would like to finalize my presentation by repeating that keeping compensated cirrhosis compensated is actually an active process for healthcare professionals, and that the natural history of compensated cirrhosis involves a timely referral for next level treatment. And one simple take-home message on how to keep compensated cirrhosis compensated involves that you make it a routine in your practice to actively decide, if possible with colleagues, whether to continue monitoring or to step up to the next level of treatment, which is frequently liver transplantation. I thank you for your attention, and I'm very willing to take questions.
Thank you, Professor Verkate. It's a great presentation, enlightening, and especially liked your clinical pearls. We all want to keep our patients that have cirrhosis in a compensated state. We have quite a few questions as expected, and if I can start with a question from Acharya. What are the major etiological factor which ultimately makes the cirrhosis liver decompensated despite all the measures that you outlined?
Yes, it's my impression that mostly it's quite commonly it's infection, an infection which actually may be a sign of an portal hypertension deranging, like a spontaneous bacterial peritonitis, but also just regular infections like other children would have, like ear and throat, airway infection. Which then indicate, which they can clear, but then they, in their labs, if you check their liver values, they make a big decline in albumin and they restore it afterwards, only partially or completely, but nevertheless, you should be aware of that. Another issue, obviously, is that upon progression of the impaired filtering function, there's portal pressure, increased portal pressure also in the intestinal wall, with the increase of the permeability and the decreased barrier function. And there's a lot of research going on now if you can actually prevent transgression of bacterial products that may actually slow down the progression of the decomposition, or actually that actually prevents the generation of bacterial infections. And I would really like to refer the audience, just after I completed my talk, I have to admit, I came across that next month, July, in Journal of Hepatology, there's a whole volume, a supplementary volume, for adult patients that upon decomposition and compensated cirrhosis and the interaction between the two, including the bacterial effects. So that's about 200 pages. So I hope you don't mind that I cannot answer all the questions on this, but I really would like to refer you to this supplementary volume of Journal of Hepatology next month.
Great. Professor Dawan.
No, thank you very much, Ankin. Great talk. I think the questions are all usually, other complications like bone disease, etc. We see increasingly, the bone health. You alluded to nutritional sarcopenia. And I think if you could promote the concept of looking at not just the fat mass and mid-arm circumference versus sarcopenia and taking it actively, I think that will be really helpful to our audience.
Thank you.
So, is sarcopenia an innocent bystander, or actually is the lack of muscle mass contributing to, if you don't have the muscle mass, you probably don't have the metabolic processes that muscle can do, and then it's an overload in the liver?
Yeah,
it's more actively participating in the compensation.
It's a very thoughtful question, obviously. What we do know, it can work either way, I think, actually. We do know if we get, we have a patient with a poor nutritional condition and poor muscle, sarcopenia, we can actually, with aggressive nutritional treatment, frequently we can compensate and we can repair. If that's the case, then I think it's a secondary effect. But we all have patients, and maybe those are the patients also that do not enter puberty and so on. We all have patients that despite aggressive nutritional treatment, we cannot get them any better. And in that case, it may actually be reversed. That it's not the primary effect, or secondary effect may be primary at some point. And we cannot get them better. And then I think it's time really to consider stepping up, although the patient may still otherwise look in pretty good shape. We know, particularly if they have reached their teenage years, they usually have a prolonged waiting time, depending on the organ allocation condition per country, but frequently they do have extended waiting time. To not wait too much longer, but really consider to step up to transplant screening and waiting list.
George, could I ask a supplementary question?
Yes.
Sure. Yes. So, Henken, you touched on a very important topic, the adolescents. And when they get 17, 18, the difficulty is the adult transplant criteria are very different, and then they don't really fit into childhood cholestatic conditions, even biliary atresia or PFI-C, PFI-C group. Do you have any advice to us, or how should we tackle that issue?
Yes, my advice is keep on fighting. Keep on fighting with allocation committees. because it's absolutely true. We know for several reasons that the adolescent group, or I should say young adults, between I would say between puberty and 25 years of age, they are in trouble both for organ allocation in many systems already before reaching adulthood, but also certainly thereafter. But also they have a higher risk of post-transplant problems, and this may actually be related because they have been longer time on the waiting list in a less favorable condition for transplant. I don't have the single solution, except that we should keep on fighting for them, because we all know that 16 or 18 years or whatever limit is there in the system, that the patient is the patient, and that doesn't matter. So we should not stop fighting for this as soon as they reach the limit and they go to adulthood, I would say.
Dr. Verkade, there are quite a few questions in the chat box, and we'll keep them live for you to answer. But if I can end with one that is very common to clinicians' minds, which is, do you use non-selective beta blockers as primary prophylaxis to prevent esophageal variceal bleeding?
I'm happy that you start laughing yourself already. Because we actually had it this week, as we speak. This week, we discussed among our group, we did not conclude, I have to say. We discussed first that we will be less aggressive than we have been so far. And that holds both for, we think if we do have an indication to go for primary prophylaxis, we would be inclined to put first beta blockade. But on indication, we may skip that. That's as weak as it is because we don't have the data. So we will not be aggressive to all patients. We will not maybe do as much standard endoscopies anymore as we have done in the past. But if we do, and we do varices beyond from grade 2, we may go to beta blockade, and maybe for those with cherry red spots, we may actually go for first banding by itself. That's as honest as I can do. There's no data, so it's not scientific, it's what we do.
Listen, as I said, there are quite a few questions. Unfortunately, we're running out of time. I enjoyed the presentation and this discussion. Thank you very much. I invite Professor Dawan to introduce the next speaker. Thank you.
Thank you, George. It gives me great pleasure to introduce my colleague, who is also chair of Liver Advisory Group to United Kingdom for Children, Tassos Grammaticopoulos, and he's going to talk to us about the COVID times and liver disease.